respected senior colleagues, the scientific committee, and my fellow colleagues. Today I'll be talking about the vulnerable plaque. And it is a quest for the vulnerable plaque because vulnerable plaques don't remain vulnerable all the time. They move on. Some of them become less vulnerable, some remain, and some become fibrosed. Now, we all know this data. This is pooled data from 4 studies, which really shows us that 70% of all the MIs are caused by lesions of less than 50% stenosis. When it came out, it created a lot of consternation from the cardiology community. But we also know that Glagov's remodeling hypothesis clearly shows that before you have some kind of a luminal narrowing, you achieve a significant amount of plaque. And we also know that the angiogram is only a luminogram, and you can see that the IVUS clearly shows significant plaque when the angiogram looks really normal. And I believe the CTA is the unmet need for the visualization of the vulnerable plaque, and you can see right from asymptomatic to symptomatic, the whole range of cardiovascular continuum, the CT can image and show you results. Now, why vulnerable plaque? When you look at luminal obstruction, when you look at classical symptoms, and then you look at functional imaging, you still don't get a patient, and you're not accurately able to tell the patient what is his future likelihood of experiencing an acute coronary event. And these are the things that we work with. If you look at last year's TCT, a paper was published, and it showed that when you differ a PCI based on non-ischemic FFR values, they actually had a worse clinical outcome compared to those with stable ischemic heart disease. So even FFR, there is more data required in patients for identification as to which patient will develop an ACS. Now, what is a vulnerable plaque? A vulnerable plaque basically is a lipid core of interest. It's a fibroadenoma with a greater than 60-degree circumferential extent, greater than 200 micrometers, and a fibrous cap which is less than 65 micrometers. And these are all the elements of a vulnerable plaque. And you can see that the lipid core, the macrophages, the neoangiogenesis, and the inflammatory thing, and the spotty calcification. Now, we are all in the pursuit, I call it the holy grail. We're looking for a technique that can really identify this plaque and then predict the next ACS. Now, CT has come on the scene by the accuracy trial, and it's established itself as a diagnostic technique, the only diagnostic technique which is non-invasive, which can look at non-obstructive coronary plaque. The ROMICAT-2 trial again put CT on the map in terms of triaging patients in the ER who did not have an ST elevation MI, and a sub-study little later on clearly showed that when the CT detected high-risk plaques, those are the patients who had an ACS. The Dutch group looked at CT and compared it with the invasive FFR, and clearly showed that the evaluation of stenosis on CT is clearly not up to the mark when you compare it with FFR. So stenosis is an issue with CT. The next on the world stage was a discovery flow trial, and this is a trial which put again CT in front stage by showing that CT FFR, which is a non-invasive way of looking at it, was almost, if you look at this curve, in tandem with invasive FFR. However, there are some outliers out here where the CT FFR will not pick them up and the invasive FFR will pick them up. So, but for most cases, CT FFR would be able to discriminate lesions which are important. The platform study then looked at the clinical outcomes when you use CT FFR as a diagnostic modality, and you can clearly see here that the numbers of downstream investigations really came down with the FFR CT strategy compared to our normal usual care strategy, and the number of hospitalization days and the clinic visits considerably reduced when you used a CT FFR. CT perfusion also has now come in the last 4 or 5 years, and you can clearly see here that this is a decreased perfusion segment in a patient with an LAD ischemia. It's almost mirroring the SPECT image which we're using as at least now is a gold standard for ischemia. However, again there is problems with the specificity, and the technique comes to just near about 75 to 80% when you compare it with the gold standard, which is FFR. So plaque analysis, I believe, is the unmet need when you want to risk stratify your patient and recognize the chance of having an ACS. So when we're looking at plaque analysis, we'll be looking at basically 3 concepts: the plaque burden, stenosis assessment, and plaque composition. Plaque burden is basically by the calcium score, and you can see that it adds value to the conventional risk factors. The more the calcium, the more the stenosis. That is also again well known. And when we looked at mortality, we could see that the more plaque that you had, that is an SI score of more than 5 segments, you can see the survival comes down. And this is Leslie Shaw's data from Stenosis Institute. And if you have more degree of stenosis, again, the mortality increases. And this is a very nice slide which shows that if you have non-obstructive plaque in a limited location, the outcomes are good. The chance of having an ACS is less. However, whether you have a significant stenosis limited or a non-significant stenosis multiple, the outcomes are similar, showing that plaque burden is as important as stenosis. Coming to composition, this was the first paper which showed that there is a correlation between lipid profiles and coronary artery plaque. And this is our own data showing that as the calcium score increases, the bad LDL or the higher LDL increases, and so does the non-HDL mirror the increase of calcium score. And we look at plaque, this is the basic classification that we look at on CT. It's a calcified plaque, a partially calcified plaque, a non-calcified plaque, which could be either homogeneous or heterogeneous, and the heterogeneous could have a napkin ring sign or no napkin ring sign. Now this is the calcified plaque, you can see, non-calcified plaque, you can see the low Hounsfield units, the partially calcified plaque and the calcified plaque. And there is now software which you can actually use volumetry and give you the actual amount of plaque volume. But this, did it really translate into clinical events? Not really. 3 out of 4 studies did not show any change when you use the plaque analysis. However, only one study which looked at a per patient analysis, the NAN study, showed that if you have a non-calcified plaque, you're highly likely to have an event. Now we went a little deeper, we dove a little deeper, and then we started looking at more plaque characteristics, the low attenuation plaque, the spotty calcification, the positive remodeling, and what I also told you, the napkin ring sign, which is an area of hypodensity surrounded by hyperdensity. And the number that we took based on number of studies was less than 30 Hounsfield units. And this is the kind of picture you can do in our labs. We can overlay the software and then assess this is the LAD here, and you can see these are lipid-rich material, this is calcific material, and this is a partially calcified plaque. And what is the correlation? Yes, the correlation with IVUS and grayscale IVUS is pretty good. And the correlation with near infrared spectrometry, again you can see it is a chemical histogram, is again pretty good if you look at CT. Now, what about the PROSPECT study? The PROSPECT study again was an invasive study which clearly showed that unless you demonstrate more than 2 high-risk PLAS, which was defined as a TCFA or a burden of more than 70% or an MLA of less than 4 millimeter, only then you could really see that the events would sort of change. Just angiographic parameters wouldn't matter. And what about CT? And this is Motoyoma's data which clearly showed that if you have positive remodeling on the CT, if you have an NCP of less than 30, or if you have spotty calcification, these are the patients who would have an ACS compared to those patients with large calcium deposits or patients with the Hounsfield units of more than 30. These patients would be seen more in stable angina patients. And to follow that, the Canadian group again showed that if you have a patient with more than 3 features of the features which I've talked to you about, the chance of ACS is much higher than somebody without it. And Motoyama again a few years later again showed that if you have a high-risk plaque, the number of events are higher and the event rate is again higher, saying that identification of plaque is important. Can we do it without radiation? MRI can do it, but this is a work in progress and it's not yet ready for prime time. Disease activity is another area that we've been exploring, and this is the PET CT picture showing the LAD lesion, which you can see here is taken up by FDG, and this is a plaque which warrants immediate attention. So PET can also be used. Coming to lesion severity, we understand that CT is not the ideal tool for lesion severity compared to angiography or IVUS, and you can clearly see here there are a lot of outliers here when you compare 64 slice CT with a cath, but we're getting better. But whatever said and done, if you use the modified Duke index, you can clearly see that if you have a left main plaque and a severe plaque, you have more events. And this is a study which really made a difference, the confirmed study, which looked at both the plaque severity, the kind of plaque, and the location of plaque. And if you come to all 3, you could clearly see that if you have more amount of plaque, if you have an increased stenosis, then you have more events, showing that a comprehensive tool can now move from a vulnerable plaque to actually a vulnerable patient identification. And this is basically what it is. So we're looking at plaque characteristics, we're looking at stenosis, and we're looking at flow by FFR. So when you have all the 3, then you seem to have a way of finding out. So I'll just leave this simple algorithm before I complete. So you have the clinical calculator, you do the calculation, you get your risk figures, that's 9%. Then you add on the calcium score for that patient. which is 2.3, and the recalculated becomes 11%, which is an intermediate score. Then you do the CT, and you see the plaque, and this is a vulnerable plaque. This is a lipid core with a spotty calcification, and the image on the right is a pure lipid core with an eccentric lesion. And when you add these two together, you add the in-segment number and the number of segments, and then you get a very nice model showing you that if you have no plaque and no stenosis, the outcomes are excellent, whereas you have a high-risk plaque and a number of stenosis, the outcomes are bad. So ladies and gentlemen, I think a comprehensive assessment on CT will be able to identify a vulnerable plaque and also a vulnerable patient. The Scott Hart trial, which was recently published, clearly showed that if you used a CT apart from standard care, you actually are able to predict which patient has events and which doesn't. Thank you very much for your patient listening.